Thank you, Chair, and I'd like to thank the Minister for coming into the Chamber as well this evening to debate paediatric diabetes services. I know an issue that the Minister herself has actually great familiarity with. And I'm sure the deputies here in the House have been contacted lately by their own constituents and parents in relation to this matter as well. Chair, there are almost 4,000 children with type 1 diabetes in Ireland, an autoimmune condition that can't be prevented or reversed. The incidence of type 1 diabetes has doubled in the past 20 years in Ireland. These children attend hospital on average 4 to 5 times a year to monitor their diabetes, and monitoring children and adolescents with diabetes in hospital aims to limit damage which diabetes can cause to the eyes, kidneys, nerves and smaller blood vessels as the child grows older. The long-term complications of type 1 diabetes, like retinopathy, kidney disease, nerve and microvascular damage, are costing the health service millions each year. The short-term complications among children with diabetes usually arise from low blood sugars and very high blood sugars and result in hundreds of children being admitted to accident and emergency each year in hospitals across the country. The fact is that 50% of children and adolescents with diabetes will have some form of serious and costly long-term diabetes complication by the time they reach 30 years of age. But for many children with diabetes, intensive treatment, for example insulin pumps, can usually reduce the development of long-term and short-term complications. At present, 21 hospitals across the country provide diabetes care to children, yet only 3 hospitals in Dublin are adequately resourced to provide intensive treatment to children who could benefit from improved control of their diabetes. The 2008 Diabetes Expert Advisory Group report admitted that Ireland has a very poor paediatric diabetes care service, with over half the patients having no access to a proper multidisciplinary team and many of the rest travelling long distances for care, such as the case of what I'm talking about this evening. Children with diabetes outside of Dublin are at a geographical disadvantage because of a lack of local services, and those in Dublin, where there are services, are also at a numerical disadvantage because so many children from outside Dublin are forced to travel here. So we have a situation where a service in Dublin is actually being stretched at 2 levels, both for its care in the Dublin area and that care that it's actually addressing outside of the Dublin region. So basically, Dublin services are literally inundated with referrals from children and adolescents with diabetes from all over the rest of the country. Now, I understand that the proposal by Diabetes Action has the full support of all the paediatricians and nurses working with children and adolescents. And I'm aware also that the department, the HSE and the new National Clinical Lead in Diabetes plans to discuss a model of care with children with diabetes in coming weeks, and I believe that this is a very welcome development. So I would like to ask the Minister this evening what measures the department and the HSE plan to take to balance this system and to make treatments equitably available to all children with diabetes. The Minister will be aware that Diabetes Action is proposing the establishment of regional teams or networks of clinicians who would offer intensive treatment at the 21 hospitals where diabetes care is currently given. The reorganisation being sought seems to me to involve only a modest increase in staff and resources and is something that should be given very, very full and proper consideration. For example, in my own constituency of Cork South Central, the Cork University Hospital, which serves over 300 children and adolescents with diabetes, will have a new consultant who will be well placed to deliver intensive treatments for type 1 diabetes to County Cork and County Kerry. But he will need more nursing and dietetic support. So while the arrival of the consultant is welcome, there is a support team that must actually come with that consultant as well. Because in the delay of those additional appointments being made, in Cork, we have at present actually an unknown number, estimated to be somewhere between 40 and 60 children, being referred to Dublin hospitals in an attempt to access intensive treatment for diabetes, such as insulin pumps. I'm concluding now, Chair, which is not available at the CUH. So referrals from across the country have congested Dublin and the Dublin diabetes services and have robbed the Cork University Hospital of the opportunity to develop the expertise to offer these services to the whole HSE region south. The reality, and I conclude on this point, Chairperson, the reality of the current arrangement leads to Cork children and their parents facing 4 to 5 trips to Dublin each week. This affects obviously things like schools and annual leave for parents and other matters. There's also a very unsatisfactory situation in that when a child is in Dublin, is the access to the medical files in Cork and the access to the medical files in Cork when a child is actually in Dublin. And this is something that also needs to be dealt with. So I'll conclude by asking the Minister here this evening, Chair, as to what action will be taken by her department, particularly with regard to diabetes services that are being referred into the Dublin region, but specifically so with diabetes services in the Cork region that could be set up to deal with the southern region of Cork and Kerry. Thank you.
Thank you, Carla. Currently, as the Deputy has already said, it is estimated that up to 4,000 children and young adults under 16 years of age would have diabetes in this country. The majority of patients have type 1 diabetes, more than 90%, but unfortunately there is an increasing number of young patients developing type 2 diabetes. The incidence of type 1 diabetes is also increasing by about 2 to 3% per year, and experts anticipate that over the next 10 to 15 years the incidence of type 1 diabetes will double. Type 1 diabetes is a particularly complex condition in children and young adults, and so it is recommended that their care be delivered in a multidisciplinary setting with access to a consultant paediatrician, endocrinologist, paediatric diabetes specialist nurse, paediatric specialist dietitian, psychological and social worker. Because of the complexity of the condition and the significant dangers of hypoglycemia, there may be a clinical advantage in having continuous subcutaneous insulin infusion therapy for children and young adults with type 1 diabetes. The HSE has established a national clinical programme for diabetes in 2010 with the express aim of defining the way diabetes clinical services should be delivered, resourced and measured. One of the key priorities is to facilitate further organised care and screening for diabetes-related complications. There are 2 proposed models of care to improve the situation of paediatric diabetes care. The first model is from the HSE Expert Advisory Group, a group chaired by Dr. Colm Costigan, paediatric endocrinologist in Our Lady's Hospital for Sick Children in Crumlin. This model proposes that care be centralised for each region in a dedicated paediatric adolescent diabetes centre, looking after at least 150 children or adolescents, and ideally the centre should be in a regional hospital that has an adult diabetes centre to facilitate transition to adulthood. The centre should be led by a paediatrician with a special interest and training in diabetes. The report also recommends amalgamation of the Dublin centres into a national tertiary centre that would act as a resource to assist the regional centralisation. The second model comes from the recent Diabetes Federation of Ireland Diabetes Action Report. This report recommends the establishment of 8 to 10 regional networks with 3 existing Dublin centres acting as a tertiary reference centre and continuing to see 1/3 of the national paediatric adolescent diabetes population. Then, within each hospital in the region from existing resources, a paediatric nurse would be identified to care for children with diabetes in that hospital. The network team would deliver care at existing centres around the country and travel to outreach clinics as required. To move this plan forward, the national clinical leads for diabetes and paediatrics are to meet in the next couple of weeks to propose the following. Establishment of a joint subgroup with representatives from the paediatric and diabetes working groups to address paediatric diabetes care. To perform a gap analysis to determine the current existing diabetes service across the country for paediatrics and young adolescents. Agree on a model of care for children and adolescents with diabetes. A standardised paediatric diabetes emergency care across the country. Standardised hospital diabetes care across the country. Develop criteria for use of continuous subcutaneous insulin infusion therapy in children and adolescents with type 1 diabetes. Work on prevention and public health policy to prevent and to aid early detection of diabetes in young children and adolescents. Ultimately, the function of the HSE National Programme for Diabetes, amongst others, is to consider which model is more appropriate, and it is working to this end. In parallel with the Department of Health and the HSE will be meeting the Diabetes Federation of Ireland with a view to progressing the issues around the appropriate model of care for children and adolescents with diabetes. Finally, There have been the following important developments in this area. The National Diabetes Programme is continuing the development of National Diabetes Retinopathy, a screening programme. While retinopathy screening is continuing in the North West region, the intention is that the service be rolled out nationally in 2012. This programme is significant because diabetes retinopathy is the leading cause of blindness and serious visual impairment in Ireland. 90% of people with diabetes will develop retinopathy, while 10% will be sight-threatened if undetected and not treated. A national foot care model has been agreed. The aim for 2011 is to establish 16 specialist multidisciplinary foot care teams across the country, in line with indicative national hospital reconfiguration, will have different levels of care for patients depending on their risk of diabetes foot disease. Taken together, it is envisaged that these planned services, once operational, will enhance overall diabetes care provided for children and adolescents in Ireland. And I do thank the Deputy, and hopefully we can, at long last, get on with providing a service to these people.